Hi folks, it's Marvin Music with MedicareSchool.com, and I want to welcome you to our event tonight. The purpose of this gathering, this event, will be to cover some important topics about projections for 2026. And then after we've gone through that really short amount of information, then I'm going to be taking your questions live. I'm in our studio today with our producer, Daniel, and so you can begin to put those questions in the chat right now. As we always ask you, please make sure that you word your question in such a way that we can understand what you're asking. Don't use so many acronyms or just try to make it so short where we can't see how what you're asking, so we want to help you is the whole point. So be sure your question is clear. You can ask me anything that you'd like to about Medicare and Social Security. Happy to cover any of those topics, and hopefully we'll be able to get to as many of you as possible. I normally wear out after about an hour and a half, so we usually have to call it quits about then, but happy to stick around that long. And so I also want to mention just two quick items. If you're not a subscriber to our YouTube channel, please become one. It's, of course, no cost at all to do that, but the benefit to you is every time we put out new content, which is quite a bit. I produce some content. We have another agent within our organization, Erica Smiley, who is really sharp and does a wonderful job with content creation. And so there's a lot available to you, and things do change, so we encourage you to be a subscriber so you can stay on top of what's happening with Medicare, and we'll do our best to make sure that we're giving you content that will really help you with your Medicare decisions. And our whole goal really as a company is to come alongside people during this Medicare journey and make sure that you know what you're doing, that you're comfortable with your choices, and are confident in those choices. So that's our goal. We also have a website called MedicareSchool.com. Where I have what we call an Essentials Workshop. And so if you're brand new to Medicare and still a little bit confused and would like to know how to connect the dots, I would encourage you to go to that website, MedicareSchool.com, and you can click on the free workshop. It's Essentials Workshop. I think it's about 50 minutes, but you'll learn so much because there's a tremendous amount of confusion, questions that people have about Medicare, and this, I think, would really clear up a lot of your confusion. And so take advantage of that resource. If you need immediate help, there's a number on the screen. We are still open. Our office Monday to Thursday is 7 a.m. to 7 p.m. It is Central Time. So if you're in a position where you'd like to actually talk to someone within our company, we'd be delighted to do that. Tomorrow we're open 7 a.m. to 6 p.m. on Friday. So we are right outside of Kansas City, Missouri, and a suburb called Overland Park, Kansas. That's where home office is, but we do business all over the country, and we can assist wherever you live. We write business in that area, so let us know if we can be of help in any way. All right, I'm going to get started. Let's talk tonight about what's happening for 2026, and let's begin just discussing the whole issue of Part B premiums. I think most of you know that Medicare is not free. The only item that actually is free, or what we refer to as premium free, zero, would be Medicare A. As long as a person has paid into the Medicare tax system for at least 40 quarters, Medicare gives you Part A at no cost, and the reason is because you've already paid for it. Right now, as you and I work, we're paying FICA taxes or self-employment taxes, and so that money that we're paying in through those taxes, part of that is going into the Medicare Part A Hospital Trust Fund. Right now, if you're working for someone, you pay 1.45%. Your employer matches that. If you're self-employed, you pay the full 2.90%. If you're high income, you pay an additional 0.9% at certain income levels. So the point is, we are all funding Medicare right now. And so as long as we pay at least 40 quarters, which is we get 4 quarters a year, so at least 10 years into the Medicare tax system, when it's time for you to start Medicare, which is typically at 65, you get Medicare Part A at zero premium for life. Now, if you don't have your own 40 quarters, you can get those 40 quarters from a spouse or an ex-spouse with certain rules that apply, of course. But the majority of people, in fact, 99% of you, will get Part A at zero premium. But you're not going to get Part B at zero premium. That system doesn't work that way. In fact, the system for Part B, as they establish the premiums, will be based upon your income. And that income is called Modified Adjusted Gross Income. People in our business, we use the acronym MAGI. So it's your Modified Adjusted Gross Income 2 years prior that will actually determine how much you'll pay for your Part B premium. So if someone's on Medicare this year in 2025, Medicare is actually looking back at your 2023 Modified Adjusted Gross Income. So they always look back 2 years. So this year's won't matter until 2027. It will matter, but not yet. Okay, so right now it's 2023. And so your Modified Adjusted Gross Income is line 11 on your tax return. Line 11, it's the AGI, and it's modified by adding back in line 2A. And 2A is tax-exempt interest. Now, the majority of people don't have anything on line 2A because they don't invest in municipal bonds or in foreign bonds, well, not foreign bonds, territorial bonds, which would be Puerto Rico, Virgin Islands, Guam, those places. They put out territorial bonds, and the interest on those, that interest is not subject to federal taxes. So my point is municipal bond interest and these territorial bonds, you have to report those earnings on your federal tax return. You don't pay taxes on it, but you report it. So when they modify your adjusted gross income, they're adding back in that information that is on line 2A. Okay, so that's the number that Medicare uses to determine how much you pay for Part B. And so this system works this way. They actually will set a modified adjusted gross income thresholds. And we have a variety of thresholds. The majority of you are either single filers or you're married filing a joint return. And so the thresholds this year are $106,000 for a single filer. If you're married filing a joint return, that threshold is $212,000. And so the threshold, if we stay at the threshold or below that, then we pay what is called the standard or base Part B premium. And that amount this year is $185 a month. Okay, so again, $106 for single people below, $212,000 below for married filing a joint return. You pay the $185 a month. Now, if you're on Social Security, that base premium of $185 a month comes out of your Social Security check. If you're not, then they will bill you on a quarterly basis. If a person doesn't like a quarterly bill, then they can set up actually a bank draft with the government to have their Part B premiums paid on a monthly basis through a checking or savings account. And then once you go on Social Security, they'll just automatically take it out of your check and then stop doing the ACH. And so that's the Part B premium right now, $185. Now, for people that are above those thresholds, again, above 106 as single, above 212 as a married person filing a joint return, then they pay an additional amount, and those additional amounts are called IRMAs. It's an acronym that stands for Income Related Monthly Adjustment Amount. And so as they look back at 2023 and you're above those limits, then you're going to have this IRMA, which is basically a surcharge. Now, I'm not going to go into all of this tonight, but there are actually 5 different levels of IRMAs, 5 levels of surcharges. We look at them like a marginal tax bracket. The more money you make, the more your marginal tax brackets go up, and the same is true with Part B premiums. The more you make, the more you're going to have to pay for your Part B premiums. All right, so today I just shared the thresholds. I shared with you the $185 for Part B. And so as we look forward into 2026, we are not for sure when any of these numbers are going to be, but we're getting close because they're engaging inflation and looking at the inflation numbers to see where we're going to land for 2026 Part B premium. And right now they're expecting about an 11% increase, thereabouts. And so right now the Medicare Trustees report is saying they believe it's going to be next year, the base premium, again, remember below the thresholds, it'll be $206.50. So again, right now, people are paying $185 a month, and that base premium would go to $206.50. So that's an increase of about 11%, right, Daniel? I guess that's right. And it's $21.50 more. Now, again, folks, not for sure on this, but it's probably going to be pretty close to that type of an increase. Now, what's also going to happen at this time is those thresholds are going to go up. Again, just a projection, but right now the single is 106 and below. That single filer threshold is going to go probably to 109. So if we're at 109 or below, we pay the $206.50 next year. You would double that for the married. And so that would be a $218,000 and stay below. Again, there's not going to be any kind of an IRMA. All right, so that's the Part B premium. That's the thresholds. And so that obviously means that if you do have an IRMA, then we're going to expect those to go up a little bit as well. Now, when you have an IRMA, folks, I want to explain something. Anytime we have an IRMA on the B, we also have an IRMA on the D, because everyone's going to get a drug plan, so they're going to actually have a surcharge for both B and D. And so that lowest level IRMA this year total is $87 and some change. So I would expect that next year that's probably going to be around maybe $91 or $92. It's also going to go up probably 4 or 5%. And then the IRMA on the high side right now is right at $527 and some change. So that's probably going to go up, and maybe $10, $15. So we expect not only will the IRMA thresholds to go up, but the actual IRMA surcharges themselves are also going to go up as well. Again, we'll have those numbers later in the year. Now, I always tell people that if you do have an IRMA, even though you're disappointed that you have to pay that extra, if you have an IRMA, that's a great problem to have, is because you are a high income. They're not taking all of it, but you are going to have to pay more for your Medicare. But what oftentimes happens with people is they have a life-changing event. And there are times when people actually can appeal an IRMA. So if I am being charged an IRMA, I'm starting Medicare in 2025 and they're looking at 2023, but I had one of 8 life-changing events in 24, 25, typically work stoppage, work reduction, a death, a divorce, a marriage. If we had that life-changing event and those events affected my income to the point that I'm now making less, then we can appeal the IRMA. We can say, hey, stop looking back at 2023. I got married, or my spouse died, or we got a divorce, or I retired, or I semi-retired. Then we can give them new numbers, and we can use that life-changing event. We can use the event for 2 years to appeal the IRMAs, because they're naturally looking back 2 years, so we get to do that. And as a firm, we help people appeal the IRMAs. And so we encourage people, if you're making less because of a life-changing event, take the time to do the appeal. We'll walk you through that process. Sometimes people don't eliminate the IRMA totally, but maybe we move down an IRMA level or 2, and it's well worth your time to do that. All right, and so that's kind of the in a nutshell what's going on, with the Part Bs. Also, just want to mention Social Security. For those of you that are taking, or even if you're not taking, right now they're projecting that the cost of living adjustment is going to be about 2.7%. Again, this is another type of an index that is being tracked throughout the year, and they compare those indexes from year to year. It's an inflationary index, and so right now the Social Security trustees are looks like they're kind of estimating about a 2.7% increase to your Social Security check. Now, one thing to keep in mind, even if you don't take Social Security benefits and get that cost of living adjustment, you're still accredited for that, because they recalculate your Social Security formula based upon a COLA increase to what we refer to as your primary insurance amount. So everyone benefits that's going to be above 60 when there's a cost of living adjustment, whether you're taking Social Security or not. Okay, so about 2.7% on that. So that's A and B. That's the IRMAs, that's the Social Security. And then I just want to mention also Part D. We're not sure everything that Medicare is going to do, but what we do know is that the Part D max cap has been established. Now, right now, what that means, by the way, max cap means that you would spend no more than a certain amount of money out of pocket on your Part D plans that are in formulary for the whole year. And that cap this year is $2,000. So as long as the medication is in the plan's formulary, you'll spend no more than $2,000 out of your pocket. I have clients right now that are on self-administered chemotherapy meds that are literally $7,000 a month. And so will they pay $7,000? No, they'll pay $2,000 for the whole year. Not $84,000, but $2,000. I had a lady the other day that was on a medication called Stelara, and her dosage and frequency, her prescription was $31,500 in 1 month. Will she spend that? No, because Stelara is in her formulary. It's therefore the max cap applies, so she'll spend $2,000, pardon me, for the whole year. And that's the benefit you all of getting a Part D plan, even if you don't take any meds. meds, get a Part D plan, because if that med's in formulary that you may need in the future, you'll be maxed out at $2,000. So in 2026, we're going to see that move up just a little bit to $2,100. So that's the worst case scenario on a Part D plan in any medication and formulary. That's the most that you would spend. Sometimes people have a difficulty coming up with that $2,100 initially, so the government has what they call a payment protection plan, where you can take that $2,100 and actually spread that out throughout the year, and so you can maybe pay $150, $180 a month instead of having to come up with all that cash the first time you get a prescription. All right, that's called a kind of a smoothing plan. And so every plan that is available can allow you to enroll in that to spread those payments out. All right, so those are some things we know for sure. We do know there's going to be a tremendous amount of disruption in the Medicare Advantage world next year for 2026. We are very close to going into the Medicare open enrollment season, October 15th to December 7th, and you'll start getting notices about your Medicare Advantage plans. I would suspect there's going to be probably 1.5 million or 2 million people whose plans will be terminated or crosswalked. There's going to be just a lot of disruption. And so if you're on a Advantage plan, you need to be looking for your annual notice of change. You should have it no later than September 30th, probably before that. But if you don't get it by then, we encourage you, call the insurance company and tell them you didn't get yours. They'll send you a copy, and you need to go through and make sure what your plan is going to look like in 2026. Again, some of you are going to lose your plan, are going to have some other options to get new plans. Those of you that are on standalone Part D plans, which means you have a Med Sup plan, then you need to do the same thing. Pay attention to your annual notice of change. We're going to have drug plans next year. There's going to be a couple less, and there's definitely going to be some changes to those as well. So the whole point is be paying attention to those notices as they come. And if you want to reach out to us, we'd be delighted to serve as your broker and help you with any plan switches that are necessary. All right, so enough said with that. If you have any further questions, happy to take those tonight. So Daniel, let's get started. Okay, so Linda's asking, is Part D required even if I can get my prescription inexpensively through a mail-in program? Okay, so it is not required. It is truly voluntary enrollment. However, Linda, I would still get one. I mean, right now, in fact, right before I came to the studio, I set a lady up on a plan, a supplemental plan G, and a Part D drug plan, and her Part D drug plan was a zero premium. And I think next year we're going to have some very low-cost ones as well. So it is true that you can use Kubin's Group, the Cost Plus program, or a GoodX coupon, or a Single Care coupon. If you get your medication cheaper that way, then that's fine. So we still get a drug plan, though, because all these other plans, Kubin's Group and Single Care, GoodRx, they're wonderful when it comes to low-cost generic medications. But Linda, if you were ever in need, let's say you need to be on Eliquis for AFib, you may get about a $35 discount. That medication is very expensive, $600. And so, but if you have a Part D plan on those expensive medications, you may have to meet a deductible, but after that, the most you'll pay is 25%. And once you've reached $2,000, you pay zero. So that's why you get a drug plan, not because of what you're taking now. You get one because of what could happen. Because, folks, you can't add drug plans anytime that you want. If you're new to Medicare, we have to start a drug plan, an enrollment within that 7 months, 3 months of our 65th birth month. The month we turn 65 and 3 months after, that same 7-month window that brings us into Medicare is the same 7-month window we have to start a drug plan. And so if we don't get one then, we can always add one, but we can only add it once a year, and that is during the Medicare open enrollment season. So you want to get a drug plan at 65 or when you retire. Now, if you retire, then you have 63 days to set up a drug plan, and that's it. And so if we don't get a drug plan when we're first eligible, again at 65 or when we retire, then we can still pick one up at a later date, but we're going to be penalized. For every month we go without a drug plan, we have a 1% penalty. Those penalties are not much, about 40 cents a month, but it's a lifetime penalty. So if I go without 1 year and I have a 40 cent a month penalty, that's $4.80 every month, then that would be added to my drug plan in the future. So those penalties are lifetime, and so they can accumulate very quickly. So get a drug plan, get a low-cost drug plan, because you may need something in 3 months that's cost $10,000 a month or cost $30,000 a month. You have no idea what the future holds. So get a drug plan. And again, use Cuban's Group. That's fine. I encourage people all the time. Compare what your plan would cost and what these coupons would cost, and go with the cheapest. So you get a drug plan for the things that you may need. That's why. All right. Thanks for the question, Linda. Let's keep going. All right, what's the best plan for COPD? Well, if I, Russell, had COPD, and what I'm assuming you're asking, whether that would be a supplemental plan or an Advantage, I would prefer to be on a supplemental plan if I had any kind of a serious issue. I mean, I have no issues. I take no meds. I'm going on Medicare in January, and I'm going to get a supplemental plan. I'm just saying that for people for sure that have health problems like that, the reason I would suggest a supplemental plan is primarily, now you got to be able to afford it. So if you can't afford it, then then I wouldn't do what I'm getting ready to suggest. But I would get a supplemental plan because if you do not get a supplemental plan within 6 months of your B date, and you have a serious issue such as COPD, then you'll never get one in the future unless you live in New York, Connecticut, Maine, or Massachusetts, and Minnesota soon. They're going to have the same law. But in all the other states presently, for you to get a supplemental plan beyond 6 months of your Medicare B date, you have to medically qualify to pick up that supplemental plan. And with COPD, you cannot medically qualify. And so depending on where you live, and 5 states do not have that rule, well, 4, and then 1 in Minnesota soon, but you don't want to put yourself in a position where you can't get a med sup. And if you wait beyond 6 months of your B date, you're not going to probably be able to get that. So you're asking me what's the best? Get a supplemental plan. I'd get a G or I'd get an N. Both of those are wonderful. Now, if you say, hey, I can't afford the premium, then what you want to do is get a Medicare Advantage plan. And you want to take the time, and we're happy to help with this, but let's take the time to make sure you're on the best one for your situation, the docs you want to go to, the hospital you want to go to, the medications that you take. So we take the time to do a thorough analysis to make sure you're on the right Advantage plan. But if you can afford a sup, that's exactly what I would do. All right, let's keep going. Okay, William. Hello, sir. I know you follow us regularly and have questions, and good to hear from you. Another possible disadvantage of Advantage plans is that you might have to change the entire plan just to find a Part D plan with your new drug in it. Comments, and I agree with you. And what William is talking about is that when you buy the majority of Advantage plans, they have embedded a prescription drug plan. It's part of the package. And that means the company that offers the Advantage is determining what plan they're going to make available to you. It's part of the package. And so sometimes people have to change Advantage plans just to get their medications covered, because sometimes the formulary would not include your medication. You may like the Medicare Advantage plan for certain reasons, but if your meds are not covered, I wouldn't be on that plan. You want to be on an Advantage plan that, yes, your doctors are in network and you're happy with the financial aspects of it, but also that your meds are included in the formulary. And so he's exactly right. Every formulary is going to be different. So when you look at Medicare Advantage plans, you have to bring that into the equation for sure. So good comment, William. Appreciate it. Okay, who's next? UHC is under investigation for fraud. Should we worry? Well, I'll say this. United Healthcare, I think, is a good company. They definitely have made some mistakes for sure. And the truth is, the majority of the companies that offered Advantage plans were doing what United Healthcare has been doing, and that is we call it upcoding. So all of them have done some wrong things. I would suspect the UHC maybe had some more violations, so that's kind of why they're in hot water. And so I think all the insurance companies, or most of them, were guilty of this. So they got caught. And so, and I think they did wrong, and I think they need to be penalized for it. So you're saying, should we worry? I personally would not. I think they're large enough where this is not going to impact them financially. We know it hurt their stock for sure. It's obviously that Warren Buffett's not too worried about that. I think he thinks it's a bargain, so that's why he's been buying UHC. So should you worry as a consumer? Maybe not. Right now. Now, I would tell you that in the last several months, they have raised their rates, and so they're not very competitive on their Medicare supplemental plans right now. And so we have not been writing them as much as what we used to. And so when we choose a Medicare supplemental company, we're looking for stability of rates, and we're looking for a very competitive initial premium, and they just haven't been there. So we truly have not been writing them much because of that. Now, we're not writing them because we think they're a bad company or because we think they're not going to be stable in the future, but presently they're just not as attractive as they once were. Okay, but again, I think they're going to come through this, probably going to cost them some money to do it, but eventually they'll recover. They're just large, and I think historically they've proven that they're going to be a main player in this space. All right, so hope that helps. I don't have a crystal ball, so I don't know exactly what's going to happen. Here we go. I'm 65, still working with medical coverage, and have decided to start taking Social Security. What is the next best step for me with Medicare when I retire in June? What plan should I take? Okay, well, first off, Michelle, if you've already taken Social Security benefits, I'm assuming that you're either getting them now or soon will, you will be automatically enrolled into Medicare A and B when you turn 65. So you're 65 already. Medicare coverage, medical coverage, I start taking. What's the next? So you're going to retire next year. Okay, so it sounds like to me you already have Medicare A and B. Is that the way you would interpret that? Okay. So when you did the application, Michelle, what I don't know, when you're saying you have medical coverage, are you saying that is through your work, or you're saying that you have Medicare? Because anyone that applies for Social Security at 65 is also given the option to enroll in both A and B. If you're on Social Security, you have to take A, but you didn't have to take B. So I don't know. You need to tell me more, because I'm not sure. The way I'm reading this is you probably have A only. You didn't take B. You did take Social Security. You're going to retire in June. So what's going to happen is, if that's the case, then what will happen is about 3 months prior to June, so back at the clock, May, April, March, right around March, if you decide that you are you're going to retire, just like you're saying here, then you're going to go through what is called a special enrollment period. It's called an SEP, and you're going to have a form filled out called an L564 by your employer to verify credible coverage, that you've had insurance and you were working or your spouse was, and that will bring you into Medicare without any penalties or problem. We call that the SEP. So the L564 is filled out by the employer. You fill the form out called the 40B, and that is used to determine, to let Medicare know when you want to start your Medicare. And so if you're going to retire in June, you're probably going to be covered through June, and then you'll start your Medicare in July. So you verify you have credible coverage, L564, and you use the 40B to pick the month that you want to start. So that's the way I would interpret your question. All right, hope that helped. John, with the G supplemental plan, I should be able to see any doctor that takes Medicare. Does that mean I can visit a doctor at a Kaiser facility? And what about a Kaiser hospital? Okay, John, I don't know. I do know beyond Kaiser, the answer to your question is yes. With the supplemental plan, you can go to any provider that takes Medicare. Now, it could be that with Kaiser, you can only be on their plan to use their facilities. All right, so I would not assume that you can necessarily go there just because you have a G plan. I have had instances where there was a doctor group that was actually owned by an insurance advantage company, and they did not take original Medicare. They only took people that were on their advantage plan. So it could be that Kaiser would not see you unless you're on a Kaiser plan, okay? So you're going to have to call them and ask them. So sorry about that, but that's the way it works. All right. Here we go. I've had different Advantage plans since 2018. I want to change to supplemental plan N and plan D for medications. Can I do this at any time? All right. So normally the answer to your question would be no, you can't do it at any time. Now, unless you move. So if you're on Advantage plan and then you move, then what happens is more than likely the plan that you're on will not be where you move. It's not going to be available. And so if that's the case, then they will terminate your Advantage plan because you moved. And then because of that move, then you should be able to be eligible to get your supplemental plan without any underwriting. That's called a guaranteed issue. And so a guaranteed issue means that there's no underwriting, but if you started Medicare before 1/1/2020, which it looks like you did, your guaranteed issue would be a Plan F. That F would be available to you with no underwriting. If someone starts Medicare after 1/1/2020, that would be a guaranteed issue G. So you're asking me about an N plan. And so to get an N plan, you would have to medically qualify to do that. And you could do that at any time. So if you move mid-year, whenever you move, your Medicare Advantage plan is going to be terminated, then you can apply for a supplemental plan. You return to original Medicare, apply for a supplemental plan, and then you can also apply for a D plan. And the reason for all of that would be termination of your Medicare Advantage plan. That puts you in a special enrollment period where then you can then make application. Again, if you're unhealthy, you could be forced to only get an F plan. But if you want an N plan and you're healthy, then they would approve that application. All right, so hopefully that helps. Tony, there's a lot of moving parts to your scenario there, so I hope I'm interpreting your question correctly. Okay, let's keep going. All right, what if your drug plan premium is zero? Does the IRMA come into play at all for the drug plan? Yes. Yeah, regardless of the drug plan premium, you still have an IRMA. So right now, let me just give you an example. The lowest IRMA right now on a Part D plan is $13.70. So if someone is on that WellCare plan that's zero premium or some other plan zero premium, they're still billed by the government for the $13.70. Their IRMA bills do not come from the drug plan. They actually come from Medicare, HHS. So you'd have a B IRMA and a D IRMA. So the premium has nothing to do with it. So if I'm below the thresholds and I have a zero, then obviously I don't have an IRMA. Then that's all you pay is zero. But if you're high income, you still pay the IRMA. All right. Jennifer, can you go over the changes to Part G in state of Arizona next year? We're one of the few pilot states. Okay, I can. What's happening is that there were, I think the list is 17 different healthcare services, and I did a video on this not long ago. I don't know if you know what the title of it is, Daniel, but it's on our YouTube channel. But there's 17 different services that have now will now require pre-authorization. And you're right, there's 6 states. It's a 5-year pilot program. And so if you have one of those 17 services that the doctor wants, it doesn't mean you can't get it. It just means that they either have to get it pre-approved, or if they do the service in advance, then there will be a medical review to make sure that that service was medically necessary. Okay, and just so you all know, prior to this, there was about a dozen different pre-authorizations that Medicare had in their system. So now these 6 states are going to have 17 more. But just to kind of keep that in the scope of things, folks, there's 7,000 different codes for Medicare procedures, 7,000. And so there was about a dozen that were pre-authorized. Now we have 12. So you're only talking about still total of 29 out of 7,000 different codes. So it's still very minimal when it comes to pre-authorizations. Now those of you that have Advantage plan, those of you that have Medicare supplemental plans, you still don't have pre-authorizations. So if Medicare approves it and doctor says you need it, the insurance company has no say-so. Those of you on Advantage plans, you have 27% of the services that you're on have pre-authorizations. And all of those 17 were already on the pre-authorization list for Medicare Advantage plans, just so you know. So I've had people say, well, does that make Advantage plans look more attractive because now Medicare has some pre-authorizations? Not really. They've added 17 and there's only 6 states that have the full 29. The other states only have the 12. And all of those are already pre-authorized by Medicare. Now, if you want a Medicare Advantage plan, get one. But again, 27% of the services that you're going to need is going to have to be pre-approved. And I know they're going to start streamlining those, which I'm glad for. And I think some companies are going to try to be more reasonable about some of these that should be a no-brainer. But the pre-authorizations will still exist and will be a big part of Advantage plans moving forward. All right, let's keep going. Is the Part D premium based on how much medication you take? No, it's not. No, regardless of whether you take meds or don't take any meds, when you enroll in that plan, that premium is the same for everyone. So what will matter is your co-pays, of course, that you're spending and all that out of your pocket based upon the meds you take. Premium is all the same. No difference at all. Great question. All right, I appeal my IRMA when I retire in 2025. Do I have to appeal again this year since they will look 2 years back? Yes, you do. It will be an annual event, and what will happen, Carol, is you will get your IRMA notice right around November, December of this year, and then you can appeal using the very same life-changing event. So yeah, that life-changing event, you can use it for 2 appeals. Okay, what will be the deductible for Part G? Right now it's $247. Actually, right now it's $257. The Part G deductible, and it's really the Part B deductible. It's just that the Plan G will not pay that for you, so it is $257 this year, and we don't know what it's going to be yet next year. Any indication on that? Okay, Daniel says that they're estimating it to be about $288, which is a pretty hefty jump. I've never seen that size of a jump before, but that could happen. So he's saying they're projecting out $288. So it's $257 right now. So that's going up about $31. All right, so we'll see. Again, that's just the projection. All right, next. Okay, so Part D, you pay a premium plus $2,000 copay, and that is correct. Your $2,000 does not include the premium that you pay. The $2,000 would include the deductible. You have to pay that and all your copays, coinsurance up to the $2,000, but not the premium. That would be separate. All right. Okay, what if you're on Medicaid? Does this transition to Medicare and help with premiums or Part D when you turn 65? Okay, so the majority of people that are on Medicaid, when they go on Medicare, they do not lose their Medicaid eligibility. Whatever state you're in, you want to verify that, but normally you just continue. What happens, though, is that Medicaid becomes the secondary payer. Right now it's the first payer, and you pay nothing or a spend down, whatever. But once you're on Medicare, then Medicare moves to the first payer position, and then Medicaid pays second. Now, what the majority, and I mean great majority of people do that have both eligibilities, we call them dual eligibles, they will actually enroll into a special needs plan designed specifically for certain groups of folks. Some of those people have chronic conditions. Others are on Medicaid and Medicare. So they put specially designed plans together for you. The state pays some expenses, and of course the federal government reimburses or pays a flat capitation rate to the insurance company. And so they put together some attractive plans. So you have very little out of pocket if you have a dual special needs plan. Your medications are very inexpensive, sometimes zero copays for all your medical services. So my point is you want to check into one of those types of plan called a DSNP, dash SNP, dual special needs plans. And again, you can call in. We write those plans all day long, and happy to help you to make sure you're finding the right DSNP plan in your particular area, which would be based upon doctors, medications, hospital choices, all that. And we'd be happy to help you with that. Give us a call. All right. Okay, how does the Part D drug plan work if the medication must be administered by the doctor in their office and not a pill or self-administered? Yes. So the Part D cap has nothing to do with those kind of medication. It's only those meds that are self-administered and covered by Part D plans. So what you're talking about is a medication professionally administered, and so that would be covered under Part B. And so you can look at it as though it's capped. Let's say you have a G plan, and for that matter, even an N plan. You would only spend your deductible, and that's it. So you're this year $257. If Daniel's right about next year, $288, and then that medication would be 100% covered. Medicare pays 80% after the deductible is met. You pay 20%. But if you get a G or an N plan, those plans are going to cover that full 20% coinsurance. So again, once you met your deductible, that medication would cost you zero. Okay, so it's actually better than a Part D plan. And we see this happen a lot with chemotherapy. It happens a lot with a medication called Prolia, which is for bone density issues. People that have osteoporosis usually take Prolia shots. Those are professionally administered, and you wouldn't pay anything beyond the B deductible with the G or N plan. All right. I'm retired military. I'll have TRICARE for life. Do I need to buy any supplemental plans? No, Greg, I would not. You have wonderful insurance. You have A and B that'll pay first. You do have to enroll in A and B, just so you know. And then your TRICARE plan will pay second to Medicare. Now, I can tell you, Greg, what a lot of people in your position do, so this is an option that you may want to consider. TRICARE agrees to either coordinate benefits with A and B, or they'll actually coordinate benefits with a Medicare Advantage plan. And so the way I would do it if I were you, if you want to explore this option, you can get what is called an MA only plan. MA stands for Medicare Advantage only, and it does not include drug coverage because you can get your drug insurance through TRICARE. It's a credible coverage plan. And then TRICARE will coordinate with the Medicare Advantage plan. Now, the benefit to you in that regard is then you get some of the perks offered by the Advantage plan. And the Advantage plan is going to pay first, and the TRICARE is going to pick up the balance. And what happens is they, meaning the Medicare Advantage company, they will give you some form of a Part B reduction. They give you a credit towards your Part B. Sometimes that's $100 a month. Sometimes it's $150 a month. The plans that are out, I don't know what that's going to be in 2026, but right now we see some plans that will actually cover your full Part B premium, so that $185. So what's happening is that Medicare Advantage company, because they don't have to cover your medications, they will give you a credit back for that $185 completely. So that's a great way to increase your Social Security check or reduce your Part B bill by doing an MA only plan. And the nice thing about that situation is this: if you don't like it, you don't have to keep it. You can change any year during Medicare's open enrollment season and get rid of the Advantage and just go back to having A and B plus TRICARE. So you can kind of try it for as long as you want. If you don't like it, go back. That's not the case for a lot of people that try Advantage and they stay on it more than a year. If they want to get out of that, in most states, they have to medically qualify to go back to original Medicare with the supplemental plan, but not you. You wouldn't have to do that. So it's called an MA only plan. We write those regularly. If you want to call in and talk to one of our agents about that, they'll give you some more details, see if there's a plan in your area that would offer that. Okay? All right, good question. Okay, we'll work to 67 under my wife's health plan at work. Will I be eligible to qualify for supplemental and not answer medical? Yes. Yeah. Just so you know, as long as you have no part of Medicare or A only, once she retires and you get off her work plan, you will apply for Medicare B. And so once you've applied for B, now the clock is going to start ticking, okay? So this period of time where there's no underwriting is called the Medigap OEP, Medigap Open Enrollment Period, and we all have it, and it's all tied to our B date. And officially it begins, once our B date begins, we have the next 6 months where we're in our Medigap OEP where there's no medical underwriting allowed. You can get any plan you want that's sold in your area, based upon your age. And so let's just say my Medicare B date was coming up. It's in September. So I would count the month of September as one of my 6 months. So B date's September, that would be September, October, November, December, January, February. So all the way from September to the end of February, I could apply for a Medicare supplemental plan, anyone that's available in my state based upon my age, and that policy will be approved. That's the 6-month window. Now, from a practical standpoint, you don't have to wait till your B date begins to apply for a supplemental plan. Most people don't. Most people are applying for supplemental plans anywhere from 3 to 6 months in advance. The supplemental plan starts on their B date, and so again, you don't have to wait. You can apply in advance, but it won't begin until B date starts. But once B date begins, we still have 6 months to make that decision. No underwriting. Okay, but after that, that would change. And Emilio, you're coming in to Medicare at 67 using the special enrollment period. So your employer is going to verify that your wife is working, you were covered by, that plan, and you'll have no problem at all coming into Medicare, setting up that B. Okay? All right, next, would you please speak to the pros and cons of Medigap attained age versus issue age premium? I sure will. Well, first off, let me say this. The majority of states have already determined what is going to be available in that state. I think right now there's 8 states that require community rated. I think there's 4 states that require issue age, and the rest of them primarily use attained age. I know there are some states that offer both. They allow both. Okay, so just want to make sure we're clear on that. So we have community, attained, and issue age. And so the first thing I'd like to comment on this is kind of a misinformation piece that people hear, that issue age policies never go up, and that is not true at all. Issue age policies, it is true, do not go up because of age, but they still take group increases. All of the different rating methods take group increases. Community goes up because of group, issue age and attained age all go up because of group. And so you understand how group increases occur. Here's the system. When you buy a Medicare supplemental plan, folks, you're going into a group. We call it a block of business. And so what's happening in the group, there are a variety of ages in there, of course, genders, there's male and female in there. And so what's happening in every group is this. You're in the group, you pay your monthly premium in. You've transferred the liability of some of your Medicare gaps to that company. You got to pay them a premium, but they also have to pay money out in claims. So the way to look at the group is money is going in through premiums and money is going out through claims. And eventually, more claims will go out than premium that's coming in. That's going to happen with all of them. Now, I don't know when that is. It could be a year that you've been on the plan or 2 years in, but it's going to happen. Claims exceed premiums eventually. And when that happens, in all states, to get an increase, to get back to even where the company was, they have to petition the insurance commissioner of that state for a price increase. So let's say that 93% of claims are covered by premiums. That means they're losing 7%. So they will petition the state insurance commissioner for a 7% increase for the whole group. And so the insurance commissioner's job is to audit the request. They're going to make sure it's justifiable, that the paperwork is done, and that it's all in line. And it usually is. And so what they're going to say is, yes, we'll approve the 7% increase, and everybody in the group goes up the same. You could be in the group and you're a 72-year-old female. You could be in the group and you're a 65-year-old male. Both of your rates are going to go up 7%. And that happens whether it's community, issue, or attained age. They all take group increases. Now, the attained age is the one that only takes increases because of age. Community doesn't. Why? Because community, everyone gets the same rate regardless of age. That's what community means. Regardless of your gender, regardless of your age, as long as you live in that community, which could be multiple zip codes, multiple counties, it could be a whole state, everyone gets the same rate. That's why they're so expensive, because the 85-year-old pays the same as much as the 65-year-old. So the 85-year-old is getting a bargain. 65-year-olds happen to pay more than really normal. And that's community. And again, there's only 8 states that do that. And so what happens, age doesn't matter with community. When it comes to issue age only matters when the policy is issued. So the 65-year-old pays less than the 70-year-old. But once they're in the group, now rates don't go up because of age. They only go up when there's a group increase, when that group is losing money. When it comes to attained age, those start off the lowest. And what happens at an attained age is I come in at 65, and then at 66, 1 year later, my rate's going to go up a little bit. On average, that's usually about $50 for the whole year. Take $50 divided by 12, that's about $4 or $5 a month. And so everyone that's in there is going to go up a little bit every year. And the idea behind attained age is by allowing the insurance company to automatically raise the rate a little bit every year, that should make the group increases less frequent and less drastic. That's the philosophy behind attained age policies. And as a practical standpoint, that usually flushes out. And so what happens, though, is we have agents that only sell issue age, and they'll say issue age better, and they're not going to go up as much. And that's nonsense. No one knows how much is going to go up because they all can take group increases. So what really matters is not issue versus attained. What really matters is what size of a group are you in? How much of a market share does that company have? What has been the rate history of that company? Have they been stable, or do they take increases more frequently or more drastically? That's really what matters. Issue age goes up. It just doesn't go up because of age. Attained age, a little bit every year. Therefore, it should minimize the attained age, those group increases. So that's kind of the philosophy behind it. But again, most states have already determined what is going to be available. All right, so hopefully that helped you. That's my 2 cents on your question. more than 2 cents, really. Let's keep going. Greg, my doctor prescribes a new drug. Can I add it to my formulary in the month it's prescribed, or must I wait until the next open enrollment period? No. Okay. The formulary, Greg, is already established. And here's the way it works. We have some formularies that have about 2,500 meds. Some have 3,000, some have 3,500. So when you look at a drug plan that has a zero premium or maybe very low premium, it's probably going to be a good formulary, but it's going to have 2,500 meds. If I look at a Part D plan that is $90 or $100 a month, hey, that's a premium formulary. Probably has 3,500 meds to choose. Why does that matter? Because I want all my meds covered, because I want that $2,000 cap. So I don't get overly worried about the premium. I mean, obviously we want the best deal we can get, but what I want are my meds covered to make sure everything falls underneath that cap. All right, and so that's the way formularies work. So you're not adding anything. So more than likely when you get a new prescription, that's going to be in your formulary. If it's not, then what can happen is you can ask for a formulary exception and have it added, and usually they will agree to that. Now, if the doc wants to put you on a brand name and there's a generic equivalent or alternative in your formulary, you're probably going to have to try that before they're going to fill the brand. Now, if you've already tried that and those don't work, they'll probably add the brand to your formulary. Okay, so it's just for you specifically. But I want to make sure you know that just because you get a new prescription, that's more likely going to be covered. Go get it filled. If it's not, we do a formulary exception, and then the following year, you're going to have to do that again if indeed it's not in a formulary. Now, what I would do the following year is I'd change plans to make sure it's going to be within your formulary. Okay, so hopefully that helps. A lot of times people think because we have our sites, we have a site, Medicare.gov, that you tell them what you're taking, and if you take something outside of that, you may not be covered. That's not true. Okay, we use Medicare.gov, and our website, we have our own called Medicare School Enroll to shop to make sure that the meds you're taking now are covered, and that technology helps us to be able to pick out the right drug plan for you. All right, so hope that answered your question, Greg. Appreciate it. All right, osteoporosis is a condition that would disqualify from passing medical underwriting, be able to switch Medigap plans in Florida. Okay, Anna, let me say this. Maybe. I will tell you this, osteoporosis with fractures, absolutely yes, okay? But we have seen carriers that will take osteoporosis as long as there's been no fractures. Now, again, it could depend on the medications you're taking and all that. So as a blanket statement, I can say what you're saying is not exactly true. Close, okay? It is true. Insurance companies don't like osteoporosis, but the question with some of them is with fractures. So you still could have some possibility. So again, from there, if you don't have fractures, then they may look at the case, look at the meds you're taking and all those kind of things, and then make their final determination. Okay? All right. Is ACE no longer writing supplements? Will they continue to support existing supplements? Yeah, absolutely, Ronald. ACE is not. Of course, they were owned by Chubb, and there's been a renaming of that division for their Medicare supplemental business. And so, but they're still servicing those. You don't have to worry about that because those plans are written for life. So they'll continue to service anything that's going on with you. You have a customer service issue, any kind of a claim problem, you can still call them. They're still paying bills for sure because it is a lifetime policy. So just because they had a change in business philosophy or business model does not mean you've lost your plan at all. They will still take care of you. And if you're our client, we'll help with that as well. Okay. All right, folks. Emily, I'm turning 65 in January. I haven't started the process and have little knowledge about how Medicare works. Can you help? I'm still working for another 1 to 2 years. Well, Emily, I turned 65 in January also, so we share the same birth month. So here's what I would do. If I were you, go to our website, MedicareSchool.com. And there's a button there for what we call a free essentials workshop. It will take you 50 minutes, and I promise you that'll give you a wonderful foundation knowledge of how this whole Medicare system works. Okay, that's the first thing I would do. If you want more than that, go to our YouTube channel, MedicareSchool.com. There's probably 500 videos, I guess, on our channel. I don't know, but there's a bunch. And so you can learn a lot that way. Now, let's talk about your working situation. You're working another year or two. If you're still going to work, or even your spouse for that matter, and you're covered by an employer-provided plan that has 20 employees or more, 20 or more, that's on the payroll, doesn't mean they're on the plan, but on the payroll, then you don't have to do anything with Medicare. You don't have to do A, you don't have to do B, you will not be penalized at all. As long as Medicare A is zero premium, which means you have 40 quarters, there's never a penalty for Part A. A lot of people hear there is, there's not if it's free. So you may want to take A only. Now, if you have a mediocre group plan or an expensive one, for me, that would be you're paying $250, $300 a month or more with a high deductible, then Medicare may be your best option. So again, 20 or more employees, you don't have to do anything. Don't have to do A, don't have to do B. If you don't have an HSA, I would do A only. And if you have a lousy group plan, do A and B. But if you have a good group plan, again, you don't have to do anything. And then you can come in Medicare later when you retire using what's called a special enrollment period. And again, on my video, that Essentials Workshop, I talk about all of this. All right, so, and folks, think about it. Medicare is glad that people keep working past 65. They're thrilled because they're not liable for you. And so as long as there's 20 or more on the plan, you're covered by a good group plan, they don't want you to go on Medicare. They're glad that you don't, and that's why they make it so easy for us to pick up Medicare at a later date. As long as you or your spouse have been actively working, covered by a group plan, you can come into Medicare at any time. Hey, I brought people in their late 70s in Medicare. They retired at 79, brought them into Medicare. Had been eligible for 14 years, but were not using Medicare at all until they retired. No problem, because they had credible coverage all the way back to 65. That's the key. All right. Need help with my mother, 92, next March. Medically, she's pretty good as Part B, but it's 565 and comes out automatically. When can I shop for a better Part B? She has no drug plan. Okay. Well, let me say this to you. I don't think you mean Part B, 565. The only way Part B is the Medicare premium, and that's $185 for most people unless she has an IRMA. But if she has an IRMA, it's because she's very, very high income. So you don't shop for a better Part B. Again, I'm not sure how to help you here because I think she probably has a part of Plan F, and that's what's gone up drastically. And so unless you live in New York, Connecticut, Maine, Massachusetts, and Minnesota after January 1, the only way to move your mother off of her Plan F that she probably has to another plan is she's going to have to medically qualify. Now, let's say that this Plan F is getting, beyond what she can really afford. What I would do in that situation, if it's that high and that unaffordable, then I would move onto some kind of a good PPO Medicare Advantage plan that has a zero premium. Because if you're paying $565, I mean, goodness, you're paying almost $7,000 a year in those premiums. You can get on typically a PPO plan with maybe $5,000 max out of pocket and come out better. Now, you have to make sure docs are covered, and there's a lot to that decision. But if she is really paying that much, if we can't get her qualified to a lower cost plan and money is the issue, then I would move to an Advantage plan. Okay? I'm a fan of supplemental plans. I love them. I just think they're quality insurance. But there are times when an Advantage is really the best option. People can't afford subs, or they don't want to afford them, then we certainly go with an Advantage. But as far as shopping for these plans, you can do that right now. So what I would do, once you just call our office, that'd probably be the best. Ask for an agent, and because supplemental plans can be changed anytime. We're not bound to the open enrollment season. Now, with her drug plan, we would have to add that, and there are some special codes. We may be able to do that at this time of the year. Our agent can tell you, or we can definitely add it later this year, October 15th to December 7th. She's probably going to be penalized since she doesn't have a Part D plan. But it would probably be worth it even if you do have to pay the penalty to get on a D plan. So again, you may be able to add that. We have special enrollments for that, or for sure, October 15th, December 7th. So call in, please, and we'll tell you what to do. And our agents will be honest with you. They'll give you accurate information, shop the plans, so you can make some comparisons and make a great choice. All right, who's next? Okay, David, we were told by your team that although UHC premiums are high, your view is that premiums should be relatively stable. Is that correct? David, I would believe that. I will tell you historically, UHC has been one of the most stable companies in the market. And what we have found is that especially as people get into their 80s, they tend just to be more stable than anyone. So would I cancel a UHC plan right now? I wouldn't. I would see what's going to happen maybe the following year, and let's see where those increases come. So my point is, I would not get off of them. Now, if you can go with another carrier right now and you're going to save maybe $40, $50 a month and you can make that switch, then I probably would do that. But if we're only talking the difference with UHC and some other carriers on the market of $10, $15, I probably would not change. Because I think for the long haul, I think they're going to prove to be stable. But $40, $50 a month, that's significant. So if you can medically qualify to move, and there is that kind of a difference, then I would seriously consider that. But I still like UHC. I still think they're going to be a good player. I still think they're a good company. Certainly not perfect, but I don't know. They just one out of three people that are on Medicare on some type of United Healthcare plan, so they're not going away, and they want to be competitive. It didn't help them to be not competitive. That's not their desire at all. They just had a lot of people on Medicare, folks. Here's what happened. There are a lot of people that, again, delayed services during COVID and then started getting services. And now what's happening, there's this new kind of phenomenon going on that a lot of people that are approaching 65, they've been putting off rotator cuff surgery, knee replacements, hip replacements. They've been putting it off until they go into Medicare. They go on Medicare, and by the way, cataract surgery falls in this category as well. They put all these off, and then once they're on Medicare, the very first month, they're getting knee replacement, hip replacement, rotator cuff. Cataract surgery, very expensive, so these companies are really seeing a lot more medical losses because of that. So these delayed services are now kind of starting to happen more and more frequently, and United Healthcare, being the largest player in the business, has had the greatest impact by this. And that's why we've seen these price increases as of late. Okay? All right. Hope that helped. Let's keep going. Kenneth, what differentiates your after the sale customer service from other companies like yours? Well, I would say the biggest difference is from a brokerage standpoint, we don't just write new policies. We service our existing clients. We call it our book of business. We manage that. We service you. So if you had any kind of a customer service problem, you call in and you'll be transferred to our customer service team, and they will help you with a claim problem. They'll help you with anything. In fact, I had one of my clients call today, didn't just have a stroke, had a stroke about 6 months ago. And she has been in a skilled nursing facility, then a nursing home, but she's doing much better, but she still needs help. And so she was needing a lift, actually a hoist, a lift, in her home. And so I spent an hour trying to track down a durable medical equipment provider that would actually help her. And we got it all worked out. Prescriptions can be faxed in, got to have clinicals to prove it. But we do things like that all day long. So we'll help you. The majority today of customer service calls are transferred to an offshore customer service center. It could be in India, China, the Philippines, all kinds of these places, because it's cheap labor. And most of these companies, and this is one of my frustration points, they make billions of dollars, and then they transfer you to a call center agent that's making $5 an hour. And so it's cheap labor. And I don't knock the people who work in those foreign call centers. They're just trying to make a living, provide for their family. What I'm frustrated is these companies making people be serviced by those folks. Many times you can't understand them. Their English is not their first language. And a lot of times they're rookies. They don't even understand Medicare well. But that's who you have to look to when you have a problem. So that's how we're different. Look to us. We have to be your agent of record. That's why we tell people, hey, you want our services, we have to write your plans, whether that's a SUP, an Advantage plan, drug plan. We have to write those plans for you to be able to assist you. Agent of record's the only one that can do that. So that's the benefit, and that's the difference. And we take that seriously, folks. We don't write a plan and say, see you later, have a great life, good luck. That's not us. We're not wired that way. We're going to take care of you, and we spend the money to do it too. Okay, next. Are flu shots no cost on Medicare, even though I've just started on Medicare in May and haven't used my Medicare plan yet? Yes. Those are actually covered by Medicare as a preventive service. You have flu shots, pneumonia shots, hepatitis B shots, and COVID shots are covered under Medicare preventive services. And then there's additional immunizations that are covered that are approved by the Immunization Advisory Board. And the rest of those are covered under your Part D plans at no cost to you. Greatest example would be a shingle shot, or that they call it diphtheria, tetanus, pertussis, that shot. It's also covered under, what's it called? Tdap, I think, something like that. Anyways, but it's covered by the drug plan. So we have some covered by Medicare B, that's those four: pneumonia, flu, hepatitis B, and COVID. And then you have the other shots that would be covered by drug plans. And by the way, kind of in my heart, I was just here thinking, I read something about the COVID shots. So that may have changed now, folks. I know Secretary Kennedy is not real fond of the COVID shots there, so there may be something there going on that Medicare may not be covering the COVID shot any longer. Don't quote me on that. I know I read something about that, so it still may be covered, but maybe there's some discussion about dropping that from the preventive list. So anyways, all right, hope that helps. Let's keep going. All right, I'll be 65 in January. If I call in to talk to your company, what information will you need from me? Well, Maureen, first off, if you're on Social Security, you're going to be automatically enrolled into Medicare, and your Medicare card is going to show up at the end of or mid of part of September. Anyone that's taking Social Security is automatically enrolled into Medicare A and B. And so I'll be looking for the card if that's you. Again, it'll come in September. Those of you that are turning 65 in December, your card's going to come this month, or came this month by now. And if you're not on Social Security, then what we would need from you, if you want us to help you with your Medicare A and B enrollments, we would need to make sure you have a myssa.gov account set up with an email, of course, and a password. And we're happy to help you with your A and B enrollments, but you would have to have the ssa.gov account. And then in addition to that, depending upon how you're going to use your Medicare, and if you're not sure, Maureen, I would go to our website, medicareschool.com, and again, click on the button there where it says workshop. It's a free workshop. It's Essentials Workshop. Takes 50 minutes. I do a new one every year to make sure it's up to date, and so you'll learn a lot there. And then depending upon how you want to use your Medicare, whether that's through a supplemental plan or through a Medicare Advantage plan, then that will determine the information that we need from you. So if you're going to do a supplemental plan, the majority of doctors take Medicare, all hospitals do, so the providers will be a no issue. But you need to decide whether you want to take a G plan or an N plan. Those are the top two plans, so learn about those. You would be paying through those through a bank draft, so we have to have a routing number and account number to set up those auto pays for you. We also have to have a separate drug plan, so we're going to need a list of your medications. And about medications, folks, we want the medication you take, not ones that, we all have people say, well, I take that PRN. Well, how often PRN? Are you take 30 pills a year? You use a tube of that a month or 6 months? So we need to know that. We don't want to guess at that, but we want to know dosage, frequency, and the meds that you're taking. If you're taking a generic, I want that. If it's a brand, I want that. If you're taking a generic of a brand, don't give me the brand name. Give me the generic. So we want a list of meds, dosage, frequency. If you're going to go with an Advantage plan, then we would have to know your exact doctors and specialists, hospital choices, and that's the ones that you see on a regular basis because we have to make sure they're in network. And then again, we'd have to have all the drug information as well on the Advantage plan because there's going to be an embedded drug plan there. So that's what we would need from you. Again, your Medicare number, if you're already on Social Security. If not, we're happy to set all that up for you. And then providers, medications, and then we can do business. And so give us a call, really. And what I would do in your situation, Maureen, you can call in any time, because most people apply for their supplemental plans 3 to 6 months in advance. What we don't know yet will be the 2026 drug plans or Advantage plans. But you can call in, and there's certain things that we could get started even now to set up your file, and then there'd have to be a second appointment after October 1 so that we can nail down those precise drug plans for 2026 or Advantage plans. Vicki, Marvin, my question is about the drug plans. When I turn 65, will the Part D plan be a guaranteed to accept just as supplemental plans are? Yes. In fact, Vicki, great question. Now, supplemental plans just have that 6-month window where there's no underwriting, but drug plans always have that rule. Okay, so there's never underwriting on drug plans. So the only criteria is that drug plan has to be available in your area, meaning it's got to be available in your zip code. And if it is, then you can enroll in that drug plan and use it. So again, no underwriting at all. So when you switch drug plans, we just find out what drugs you're taking so we can find the right drug plan that's the best fit for you for the following year. Okay, so hope that helps. Great question. All right, I'm enrolled in WellCare RX plan and my primary care prescribed Wegovy. Once I meet my deductible, will my cost be zero? Okay, so first off, when it comes to Wegovy, I am assuming that you needed that for reasons, health reasons, other than just weight loss, because my understanding is those meds are still not covered unless you're a diabetic or there's some other heart issues, so it's not just weight loss. So if they prescribed it, I'm also assuming that through WellCare, that was a pre-authorization medication, pre-authorization. So if it was approved for you, then it is true that once you've met your deductible this year, that's $590, then what happens is you go to phase 2. So it won't be zero yet. It's going to be 25% of the retail cost. So once that total cost, they call it true out-of-pocket. Sometimes that's money out of your pocket. Sometimes it's just the retail cost of medication. But once we've reached $2,000, then it's going to be zero. And what I'm trying to teach you here is that there's actually 3 phases of drug plans, 3 different copays. The first one, you're responsible for 100% of the drug cost until you reach the deductible of $590. And then you go to the initial coverage, which now you just pay 25% of the retail cost. And then that stops once we have spent out of our pocket $2,000, including the deductible. Then we go to zero. But it's not zero immediately once you've met the deductible. Okay? Shortly after, probably, but not immediate. All right, let's keep going. All right. We're still here. Daniel's looking for some questions here. Sometimes these questions are repetitive, and so if I just answered it in the last couple of minutes, he's not going to have me answer it again.
Yeah, this is simple.
All right, here we go. If I'm turning 65 in June, when is my enrollment period? Okay, Tammy, as long as your birthday is June 2nd through the 30th. Your enrollment period is 3 months before that. So you back up the clock from June, so May, April, March. So your enrollment period begins March 1, and then we'll go 3 months past June. So that would be July, August, and September. So from March 1 to the end of September would be your 7-month window. Now, if your birthday is June 1st, that's different, because if you're born on the 1st, they actually move the clock back a month. And so if you're born June 1, your Medicare eligibility date would actually be May. So we'd do 3 months before May, month of May, 3 months after would be your initial enrollment period. So that would be the one exception. So the 2nd to the end of the month, it's always your birth month, go 3 months before, 3 months after, that's your initial enrollment period. Okay? All righty. In Missouri, if you're in original Medicare, want to switch to Advantage, do you have to medically qualify? No. In fact, in no state do you have to medically qualify to get an Advantage plan. Okay, you can move to any Advantage plan that's sold in your zip code or your county, wherever, whatever area they have for you. It's typically by zip code or county, and you can move from SUP to Advantage. Now, keep this in mind. If someone has been in original Medicare and they want to get an Advantage plan, if they're beyond their initial enrollment period, that's that birth month, 3 months after. If they're beyond that, then you can only add an Advantage plan one time a year, and that's October 15th through December 7th. So you can't add Advantage plans anytime you want to, unless you're in that, again, that initial 7 months. Remember, 3 months before, month off, 3 months after, you can do it. But after that, just October 15th to December 7th, and then that new plan you picked out during that 7 weeks, that new plan starts January 1. Okay. Now, if someone has an Advantage plan on January 1, then they actually have the first 3 months of the year called the Medicare Advantage Open Enrollment Period where they can switch those plans. But you have to be on one to be able to get a different one January 1 after. Okay? Yeah, there's different enrollment periods for Medicare plans. Okay, Nancy, what if I already have a drug plan for years? If I took a year off from it, would there still be a penalty? Yeah, absolutely. Yeah, so for every month that you go without a drug plan, then you're going to have a 1% penalty. And that 1% penalty is 1% of the national average drug plan, which is basically about $40. So the penalty would be 1% of that, which would be 40 cents. So for every month you go without, you're going to approximately have about a 40-cent penalty. So again, 12 months without times 40 cents would be $4.80. And so whatever your new drug plan is, they're going to add $4.80 penalty to that if you went without a year. Even if you have a zero premium plan, you're still going to pay $4.80 to the government for not having a plan. So 1% per month. All right, does Plan G cover anything that is not covered by the original Medicare? I read Medicare is rejecting many claims from doctors lately. Well, I will tell you this, Jennifer. I don't know where you read that. I believe you, of course. But as far as Medicare rejecting claims, listen, folks, they pay well and they pay fast. All right, so if they're rejecting claims, that's typically a coding problem because Medicare is happy and willing to pay for all these services, and they pay great. I will tell you, folks, I think we have 70,000 clients, and we never get complaints about this. So, Jennifer, I'm not sure who's saying that. Now, could I believe there could be some issues, maybe with some Medicare Advantage issues because of some denials? That happens. But in the original Medicare system, again, it's, for me, my opinion, it's almost non-existent. So we have to say, why didn't they pay the claim? And more than likely, it's a coding issue. So that provider better submit it correctly. And if they code it correctly, that's going to be covered. Now, back to your question about does G cover anything that original Medicare doesn't? The answer is only one item, and that is foreign travel emergency benefits. Because the way to look at this, Jennifer and everyone else watching, Medicare supplemental plans follow Medicare. They don't make any coverage decisions. Medicare and your doctor make all the decisions, and if it's covered by Medicare, then your supplemental plan is going to follow. If you have a G plan, you pay the first $257 and you're done. So it's never an issue. But what happens with people who have problems outside of the U.S. or outside the U.S. territories, Medicare didn't cover anything. So this is an opportunity for then the Medicare supplemental plan to pay when Medicare didn't, and it's foreign travel emergency. And it's a $50,000 lifetime benefit. That is basically money set aside if you have a foreign travel claim. My worst case that I've had so far, I had a lady that I was on vacation in Ireland, had something go wrong with her liver, and she was hospitalized 4.5 weeks. The bill was $172,000, and Medicare paid nothing in Ireland. So she had a plan, and it paid $50,000. The way that works is you pay a small deductible, you do $250, and they take the balance after the deductible is applied, and the Medicare supplemental company pays 80%, you pay 20%, but their 80% stops at $50,000. So she got into hers for $50,000, so she had a $122,000 claim left, balance, and she had a $100,000 travel health insurance plan. $100,000. So it paid $100,000, so she had to pay $22,000. Medicare paid nothing. So your question is, will the G cover? Yes, because it does include $50,000 of foreign travel emergency. If you're on a Advantage plan, can you still get a standalone drug plan? Occasionally. And the way that works is this. There are actually 3 types of Advantage plans. There are Advantage plans that are called MA-only plans, where there's no drug plan, but that's for somebody that gets their meds through the VA, TRICARE, or FEHB. That's MA only. The next kind is called MAPDs. That's Medicare Advantage that includes a prescription drug plan. Okay, and then they have one that the acronym is PFFS, Private Fee for Service. And this is a type of a Medicare Advantage plan. And sometimes private fee for service will have an embedded prescription drug plan, and if they do, you have to take it. But sometimes they don't, on purpose. So it's a private fee for service, meaning it's still an Advantage plan, but that is going to cover all the things that Medicare would normally cover, and then they allow you to get, the system allows you to get a standalone drug plan in that situation only. Okay, so it's very limited. There are a lot of areas that don't even have private fee-for-service plans, but if you're in an area that does, then yes, you can pick out your own standalone drug plan on an annual basis. All right, someone asked if you need to appeal the IRMA the next year. Why is that? I appealed my IRMA last year and won. My income now is not going to put me over the limit. Well, the reason for that is because let's say that you've been traditionally high income. So right now, 2025, they looked at 2023, and you appealed so that your 2025 Part B premium will be reduced. So as we move into 2026, if your income was high in 2024, you're going to be charged an IRMA again. So you have to appeal again. So you can use that life-changing event for 2 appeals. So they naturally look back 2. So in the appeal, you can give them last year's numbers or you can project this year's numbers. So in 2026, you can give them a 2025 or a projection for 2026. That's the way it works. So that's why it can continue to occur. And by the way, those of you that, let's say you semi-retire, you actually then could appeal 4 times because you could semi-retire and use that life-changing event for 2 appeals. And then if you fully retire, now you have 2 more appeals you'd be eligible for because this is a different life-changing event. And I've seen people do that. Okay. Sue, my husband is on Medicare Advantage plan for 2 years. He worked with your agent to switch to a Med Sup plan effective 10/1/2025. He medically qualified. That's great. I thought he'd have to wait until 1/1/26. Is this okay? All right. So, Sue, what I guess what you're saying is they made that plan go effective 10/1. I do not know all the circumstances. Sue, I want you to do me a favor. I can give you some answers here, but here's what I want you to do. I want you to call our office. I think she's gone for the day, and I want you to ask for Christina. Okay, please call in, call the 800 number, ask for Christina, and let her check into this for you. Let me find out, because I don't want to say something that's incorrect here. As a general rule, people that are getting off Advantage plans and medically qualifying to get supplemental plans, we normally would make those effective 1/1/2026. So I'm not sure how this was set up, but let's double check. And we will do so. Tell Christina that I said for you to call. And if you can, Daniel, maybe you could text Christina or write Sue's name down, so we'll be expecting to hear from you. Just ask for Christina. We only have one Christina here, and she will check into your situation. We'll make sure that it was set up properly. Okay, so let me delay the answer until I know a little bit more. Okay, let's keep going. Can you delay Part A and B if you have HSA through work till you retire? Yes, you can, as long as you're not taking Social Security. You don't have to have A, and you don't have to have B. Okay, now, here's what's going to happen, Brian. And I don't know when you're going to retire, but let's say you decide to retire at 67. What's going to happen is you're going to enroll in a Medicare probably about 2 or 3 months prior to your retirement date. So what they're going to do is from the month you retire, they're going to backdate your A date 6 months. Now, when they backdate, folks, they never backdate before 65, but they backdate 6 months or to 65, whatever is soonest. So, Brian, if you work to age 67, and then you're going to plan to retire, again, you're going to probably apply for Medicare 2 or 3 months in advance. So when you retire, then they're going to start backdating that A date 6 months. So technically, you cannot put any money into your HSA once that A date has been established. Now, if you're maxing out, that's going to matter because they don't prorate. They don't let you put the annual amount in. They prorate those remaining months. Now, if you're only putting in $50 a month, it's not going to matter. But backdating of the A date for people that are maxing out, they need to know that once that A date's established, no new money can go into your HSA. You can prorate up to that point. Like right now, I think we can put in I think the amount is $4,350 for an individual. We can put an extra $1,000 in if you're over 55. That's called catch-up. So you take that $5,350 divided by 12, which is, I think, is about $445 a month. You can put that in. But if my A date is, let's say, is going to be July, that means if I was maxing out, I can only max out during those 6 months. From the 7-month on, I could not max out. Okay, that's the way it works. So it is a prorated amount, and they're going to backdate A. So don't forget that. Okay, let's keep going. Mary, starting Social Security this year at 65, my spouse is not ready to take Social Security. Can I take spousal benefits if his Social Security benefits is higher than mine if he will not be applying yet? No. In the old days, you could do that. But if we take spousal now, your spouse has to be taking in order for you to get that. So if he's not taking, you're not eligible for spousal. Now, what you can do, if you want, you could take your own. You're going to be penalized about 12%. And then when he does take, then you would be eligible to apply for spousal. Now, you're still going to have a small penalty for sure because that penalty carries over into spousal as well. So the point is, if you take now and then when he gets ready to retire, whatever his benefit eligibility is at his full retirement age, you'd be eligible for 50% of that, less penalty. But it could be that 50% of his, even if there's a penalty, it would be greater than 100% of yours. So you would then apply for that spousal benefit, and then they would give you the difference. That's the way it works. So let me keep it simple. Let's say that you're eligible for yourself for $1,000 on your own, and he's going to be eligible for $3,000, and half of that would be $1,500. You get $1,500 less penalty, and so if that amount is greater than your own, they'll continue giving you your $1,000, and then spousal would be the difference. So it could be another $350 or $400. Okay, so you still get your own, and then they top it up to that spousal amount. All right, Jody, started Medicare on 8/1, have A, B, D, and G, recently diagnosed with cancer, 3rd time. Wow, I'm sorry to hear that. Okay, non-Hodgkin's lymphoma, 3rd time. Will my Plan G bill me a higher rate based on my health? Absolutely not. Yeah, there's no additional money for your G plan at all. There's no really additional money for anything. As far as Medicare doesn't charge you more, drug plan doesn't charge you more whatsoever. So can I go to cheaper G plan without underwriting? And the answer to that is usually no. Now, if you live in a birthday rule state means that that state has some special rules right around your birthday. Sometimes it's from your birthday for the next 60 days. Sometimes it's 30 days before your birthday, 30 days after. It varies. But if you live in a birthday rule state, you could move from a G to a G, sometimes even a G to an N, and get a lower rate with no underwriting. Birthday rule states right now are New York. Let's go back. Let's go west coast to east. California, Oregon, Washington, Idaho, Nevada, Oklahoma, Illinois, up to age 75. Missouri, it's same concept, but it's tied to the anniversary of policy. Louisiana, Maryland, I think Kentucky is now, I'm pretty sure Maryland. Virginia, Minnesota will become one in 1/1/2026. So there's about a dozen states right now. If you live in New York, Connecticut, Maine, or Massachusetts, you can do that as well. It's not birthday rule state. Those are different open enrollment times when you can get any med sup you want in those states. So again, there are several states where you can make that move with no underwriting. But if you don't live in a birthday rule state or in an open enrollment state like New York, Connecticut, Maine, or Massachusetts, or in Missouri, then the only way to move would be through underwriting. And with cancer, that's not going to happen, okay? It just won't. All right, so hope you recover from this. Retired military, 100% disabled from the VA. I understand I will have TRICARE for life when I sign up for Medicare. Can I have TRICARE for life and an Advantage plan simultaneously? Yes, you can. In fact, many people with TRICARE do that. And so the way it works, you have to be enrolled in A and B, and then TRICARE will coordinate with A and B, or TRICARE will coordinate with an Advantage plan. The benefit of you doing an MA plan, you would get a Medicare Advantage only. You won't get drug coverage. in your drug plan. Keep getting your meds through the TRICARE insurance. And because you get your meds through TRICARE, then what will happen is that Medicare Advantage only plan will give you some sort of a credit back for your Part B. Sometimes it's the full amount. Other times, $150 a month. So it's a nice advantage. Plus, you can use some of the perks that come with the Advantage plan that are not included with TRICARE. Advantage plan pays first. TRICARE should pick up 100% of the balance for you. So very, very common thing that TRICARE people are doing today. And if you don't like that system, you can always go back any year during Medicare open enrollment and just get just keep TRICARE coordinated with A and B. So I'd look at that. We write those plans all the time. Excuse me. All right, folks. Okay, well, you can see my voice is worn out as well. Hey, thanks for watching. Listen, we'll have another one of these next week. And don't forget our event on Monday nights as well, Monday night, 5 p.m., and then these on Thursdays at 5. But I'm glad you joined. I hope you learned. If we can help in any way, please reach out to us. You have to reach out to someone. You reach out to us, you'll be well taken care of. It'd be our privilege, really, an honor to serve as your Medicare broker. Let us know if we can help. Thanks a lot.